Good afternoon and welcome everyone to our online information and support session. This is the last of 8 noon-hour webinars hosted by the Breast and Gyne Cancer Center of Hope. My name is Kathleen Helgeson and I'm the coordinator of the Patient and Family Resource Center. I'm joined today by Angela Martins, dietitian here at Cancer Care, who will be answering your questions and sharing her knowledge about nutrition during and after cancer treatment. We're very pleased to offer this session with the funding support of the Cancer Care Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, and Dene people, as well as the homeland of the Métis Nation. It's important for us to foster inclusivity and reconciliation and encourage others to do the same. Before we continue, there are some basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your video are turned off. If you have a question for Angela at any time during the presentation, just click on the Q&A icon and type your question. You can also choose to ask that question anonymously by checking the Send Anonymously box before you click on the blue arrow to send. Our guest speaker, Angela Martins, has worked as a registered dietitian at Cancer Care for the past 20 years. Welcome, Angela.
Hey, thanks for having me, Kathleen, and good afternoon to all the participants as we do our future virtual sessions here with you. Thanks for joining in. I know Kathleen has some poll questions throughout the presentation today, and I don't have an enormous amount of slides, so hopefully we'll have lots of time for people to ask questions and try to make this as interactive as possible. I'm just going to bring up my screen here.
Sure. Maybe while you're doing that, Angela, I'll launch our first poll because we thought it might be helpful to kind of get a sense where you might be on your cancer journey, whether you're in active treatment or it's your past treatment. So I will launch a poll to your screen. And this one is just asking you kind of where you're at. So hopefully you're seeing that poll now and you can vote or give us your feedback. And if you don't see the poll coming up on your screen, feel free to write your response in the Q&A and Ellie will relay the response to us. So Angela, are you seeing some of those results coming in right now?
I'm seeing the poll questions. I haven't seen the results quite yet.
Okay, all right. So we're getting about 78% of our people having voted, and it's actually going up a little bit more. So we'll just give it another few seconds. Okay. So now I'm going to share those results with you, and then we'll give us a better idea of where you're each at in terms of the cancer journey. Can you see that now, Angela?
I can, yeah. Thank you for doing that. So, yeah, obviously we can see from the poll results that the majority of the participants here are not on active treatment. Most of them have finished treatment, so that's good to hear because I am going to talk a lot about, what is the evidence about, what should you be eating after you've gone through cancer treatment for breast or gynecological cancer. So that's good to see that most of you are sort of in that part of your journey.
Okay, I'll just stop. I'll close that screen right now for you. Okay.
Yeah, okay, so hopefully you can all see my screen. The overview of today's presentation is I want to just really talk a little bit about sort of the benefits of good nutrition after a cancer diagnosis. I will be speaking a little bit about, what our nutrition recommendations are during active treatment and after treatment. So again, I won't spend a lot of time in the during treatment phase because I realize that most of you are probably post-treatment at this point. And then I'm going to just end by talking a little bit about nutrition services at Cancer Care Manitoba. I'm sure there are individuals out there who have had contact with a dietitian along their journey already, but just for those of you that haven't, just talk a little bit about our services and how you can access them. Yeah, so I think, again, when we think about sort of that cancer journey or cancer trajectory, we often talk about sort of this continuum. So obviously everyone on the call, I would suspect, has had a diagnosis of cancer. So you're on the right-hand side of that continuum, right of the diagnosis point in yellow there. So I think when we talk about nutrition, we have to think about, what are we telling people in terms of primary prevention? So again, what should we be telling people about their diet in order to prevent cancer in the first place? What are we telling people about their diet when they're going through treatment? And then, what is the optimal nutritional recommendations for someone who's post-treatment and maybe concerned about, cancer recurrence and what they can do to help to hopefully minimize their chance of their cancer coming back. So keep in mind that when we talk about cancer survivorship, we're talking about that point in time after someone has been diagnosed with cancer. So survivorship really starts at the time a person has a diagnosis of cancer. And like I said, nutrition recommendations may not be exactly the same depending on where an individual is along this cancer trajectory. So again, we're going to talk about, nutrition recommendations during treatment and what would be some considerations in terms of diet in the post-treatment period to hopefully improve health and prevent cancer recurrence. So generally in speaking, we always say that eating well is one of the things you can do to help keep your body healthy during and after cancer treatment. I always tell patients this is the one thing that's usually in your control. You can decide when and what you're going to eat. And that is important for helping you, get through treatment and recover from treatment and have good health after treatment. Eating well is important to help promote tissue healing. Obviously, we know with many of our cancer treatments, those treatments, they damage cancer cells in the body, but they can also damage healthy cells. And we want those cells to heal and regenerate. And there's, like I said, there's tissue repair going on, blood building that has to go on, and diet, making sure that you're eating well plays a role in that. We also know that eating well helps to maintain the health of your digestive tract and your immune system. And we know that, immune systems can be affected by cancer and cancer treatment as well. And we also want to help prevent any unwanted weight changes and minimize muscle breakdown. So we know that for a lot of individuals who go through cancer treatment, there can be significant changes in their body composition. We often see, and this is fairly common in women's cancers, that we see that there can be loss of muscle during treatment, and there's many reasons that contribute to that. And we can also see increases in body fat. So sometimes there can be sort of these unwanted body compositional changes that occur. So just I'll have a few slides here just referring to some of the common nutrition recommendations that we give to our patients who are actively going through treatment. So whether that's, recovering from surgery, or going through a course of chemotherapy or radiation therapy, or for some people it might be hormonal therapy or immunotherapy. But generally we tend to sort of recommend that people pay a little bit more attention to how much protein they're ingesting, because we know that the body needs protein. Protein's an essential nutrient for our body. And we know that there's higher needs for protein when healing and repair has to take place. So we know that protein, is needed for repair of body tissues. It helps to maintain a healthy immune system. It's a very important nutrient for building cells, especially blood cells, hormones and enzymes. So it's an important building block in our body. And it's also important for maintaining muscle mass and strength. So protein, like I said, is one of those essential nutrients. And we want to make sure people sort of put that front and center when they're going through treatment. Or there's just an overhead announcement here. Okay, we know that our bodies require sort of extra protein than normal anytime that there's healing that has to take place. Or so I always tell my patients, listen, if you've gone through surgery, or if you're in a car accident, or if you sustained a major burn to a good part of your body, or you've gone through radiation or chemotherapy, those are all times where your body is trying to do more healing and repair. So that these are times where the body's need for protein is going to be higher than normal. So again, you want to make sure that high quality protein choices are included at all meals and snacks. Again, it's a very essential nutrient. And there I've listed some of the good sources of protein. I think one of the questions that I often get from people who are newly diagnosed with cancer is, should I become vegetarian? And I think the answer to that isn't yes or no, but I think I always sort of try to say to patients, listen, you need to consider that your body needs extra protein. And if you, decide you're going to become a strict vegetarian, it's probably going to be more difficult for you to ensure that you're getting adequate protein during that time. So sometimes making really radical changes in your diet, especially in regards to protein intake, may not be the best timing for those changes to take place.
So Angela, just a couple questions around the protein. So you mentioned about consuming more protein than normal. What would be the normal requirement for an adult, like in terms of how many grams of protein should we be getting every day?
Yeah, that's a good question. I think, as a general rule of thumb, I would say as a minimum, we probably want to be getting at least 1 gram of protein for every kilogram of our body weight. So if you're using pounds, if you're not familiar with kilograms, it would probably be, 0.5 grams of protein per pound of body weight. Now, if someone is quite overweight, we may not calculate that requirement based on their actual weight. We might, maybe use a reference weight or a lower body weight to calculate that. So I say for a lot of my patients, unless you're really slim and small, you're probably going to need close to 100 grams of protein a day, I would say, as a general rule of thumb. So,
that's a lot.
To get that much protein, yeah, you really have to plan for it, right? Because again, if you're not, planning your meals and your snacks around high protein foods, you're probably going to have trouble getting to that amount of protein.
And Angela,
and again, sometimes to eat more protein, you have to think about, well, what do I dial back on? Maybe I have to eat less of the bread and the pasta and the rice, like some of those high carbohydrate foods, which aren't as essential in the diet. So yeah, sometimes you have to make room for more protein and make that a priority. Unfortunately, protein foods are often more expensive too. So it can sometimes drive up your food costs. But again, you have to think about, am I eating foods that my body essentially needs, or am I just eating foods that are fillers that don't really give me the nutrients that my body needs to stay healthy and get through treatment?
Angela, just one more question. Should people be considering protein powders then to supplement their diet with extra protein?
Well, I think for individuals who just can't get enough protein in from regular food, like if there's issues where you just can't tolerate that much protein, or, I see a lot of patients who have swallowing issues, so a lot of those high protein foods, they might have trouble consuming. So then we would often recommend a protein powder to kind of fill that gap. So my first piece of advice is try to get as much protein from real food, because you have to remember, when we eat high protein foods, we get other nutrients along with those foods. If you're using an isolated protein powder, you're generally just getting protein and you're missing out on the vitamins and minerals. For the patients who I have who are losing lots of weight, I don't want them getting all their protein from protein powders, because those things typically are fairly low in calories. So for some of our patients, we're concerned about their body weight too. So there again, you want to be getting higher calorie protein sources. And then that's not obviously always provided in a protein powder. I often say protein powders are marketed to the people who don't want to gain weight, right? The fitness people and the bodybuilders. So I think there can be a use for protein powders, but again, I think you have to try to optimize your protein intake from real food first if you can. All right, I just wanted to talk a little bit about the importance of fluids too. I think we can't, overestimate how important fluids are, especially when you're going through treatment, and in particular chemotherapy. So we always try to push the fluids for our patients, because again, that's important to protect some of your organs, such as your bladder and kidney, when you're going through toxic chemotherapy. Most people need at least 8 cups of fluid every day. So keep in mind that, some of that fluid can come from foods that are hot, that have high water content as well, things like vegetables and fruits. But it is important to stay hydrated. I think that's sort of a key component of getting through treatment in a good state. Try to sip on fluids sort of throughout the day. Again, doesn't have to be plain water. If someone's losing weight, I'm going to tell them to drink more milk, for instance, or soups. Anything that's fluid at room temperature sort of counts toward that fluid intake. So again, for some of our patients, if they're losing too much weight, we might suggest that they try to select other types of fluid. But I think, just staying hydrated is really, really important, especially when people, like I said, are going through active treatment. I think the other consideration when people are going through active treatment is that if you are developing treatment-related side effects, that may give you a reason to also modify some of your food choices. And again, that's another reason why people will come and see the dietitian when they're going through treatment. If they're having, issues with nausea or taste changes or, having lots of diarrhea, there can be nutritional strategies that can help to manage those side effects in addition to medications. I'd say the taste changes are probably one of the most difficult side effects to manage because we don't have medications we can give people to help with their taste changes. So again, sometimes people are having to modify their normal diet because they're trying to manage some of these side effects. And some of these side effects get really concerning. It can lead to treatment interruptions or discontinuation of treatment. So I think, again, that's sort of another place where we would possibly suggest different types of foods or the avoidance of certain foods if people are having specific treatment-related side effects. And keep in mind that some of these side effects can continue on even in the post-treatment period and can be, in a small percentage of people, they can have very long-term issues with perhaps diarrhea or even taste changes. So that can really hinder their nutritional intake as well. But let's switch gears a bit and talk about, what should people be eating after they're finished treatment? I think the goals for after treatment is we want to make sure that people are eating a healthy diet, hopefully to reduce the risk of cancer recurrence and other chronic diseases. And I'm going to talk a little bit about this and where the research is on this and where the gaps in research are here. I think achieving a healthy body weight, I think that, again, there's lots of sort of research out there to say that, listen, being at a healthy body weight may be one of the most important things people should work on, especially after treatment. We know that's very important for many women's cancers, such as breast cancer and certain gynecological cancers. And then as I mentioned, after treatment, people may need to still continue with specific diets or avoidance of certain foods if they're dealing with chronic side effects. So I've used the example here, for those of you who might have had radiation to your pelvic area, and if you're having ongoing issues with diarrhea, even after treatment is finished, a low fiber diet may be your default diet after you've finished treatment. And that's okay. It's just that you have to sort of figure out what foods your body can tolerate and handle. So again, unfortunately, some people are dealing with chronic issues in this regard.
Angela, there's a related question that I just wanted to pose from one of our viewers asking about how to manage gas and bloating from foods like vegetables. Should they be avoiding those foods?
Yeah, and that's a great question because I think sometimes the gas and bloating, even if a person's not having diarrhea, they might have those GI-related symptoms. Yeah, again, I think, when you think of where does gas and bloating come from in the digestive tract, it tends to come from the fermentation of starches and fibers. So again, if you're eating a high fiber diet, you're likely your body's going to produce more gas and bloating. So often it means sort of reducing your fiber intake. Again, hopefully it doesn't mean cutting out all sorts of vegetables from your diet, but how you prepare them can help with that. So often, again, if there are foods that that are causing you to have more gas and bloating, you probably want to dial those back in your diet. staying away, like I said, from eating a lot of fermentable fibers. Some people find that certain vegetables like cruciferous vegetables can be very gas producing. So like things like broccoli and cauliflower and onions. So it may mean avoiding some of those foods. For some people, if they have sensitivity to lactose, which is the sugar found in dairy foods, they may find that switching to a non-dairy milk or limiting ice cream and foods like that may help to reduce their gas and bloating. So again, I think the one thing I will say about fiber, because I think, the messages out there are that people should eat tons and tons of fiber in their diet, but you have to remember that a lot of people just can't tolerate lots of fiber. And fiber is actually a non-essential component of our diet. So I always tell people, if you have to be on a low fiber diet long term, don't worry about that. Our bodies can get by without fiber. And probably the best example of that is when we think of people who are maintained on long-term tube feedings. They get very little fiber in their diet and they survive. It doesn't kill them. So again, I think fiber is important in the diet, but it's not essential. So if your body cannot tolerate a lot of fiber, it's okay to dial that back. So for some people, it may mean, eating more of their vegetables cooked or in a soup format or vegetable juices instead of eating lots of raw salads, for instance. So I know that can be difficult if prior to treatment, you ate a lot of those foods and you tolerated them. And then after treatment, you have less tolerance or they become more gas producing. They may just not be, high fiber intake just may not be appropriate for everyone. And I think people shouldn't worry about that, but it's, like you said, it can be concerning because we feel that, if I'm not eating a lot of fiber, my body's missing out. But
there's another question relating to someone having problems swallowing during treatment and having a lot of digestive tract and mouth issues, and asking if there's certain things that can help bring your digestive tract back to normal and to a healthy place again. Are there certain foods that can assist with that?
Well, I think, again, we have to think about what does our body need to essentially survive. So obviously we need good quality protein in our diet. We want to get vegetables in there if we can tolerate them. So our body has an essential need for protein. We have an essential need for certain fatty acids. So we have to get fat in our diet. We need vitamins and minerals. And obviously, things like fruits and vegetables are good sources of vitamins and minerals. But for some people, if they can't tolerate a lot of those foods, taking a multivitamin mineral supplement may be necessary. We obviously need water. So again, I think number one is if someone's just finished treatment, sometimes the most important thing is just time. Like their digestive system just needs time to heal and to recover. If people have been on lots of courses and antibiotics, that will change your microflora and the gut bacteria that you have. So again, it's very individual depending on what type of treatment you've had. But like I said, sometimes time is important. Trying to build back some variety in your diet as you can tolerate it is important. But yeah, it's like I said, I think it's different for every person depending on what kind of medication they've been on, what their treatment has involved, whether they've had part of their digestive tract removed, with surgery. All of those things impact that. So hopefully I've answered your question there. All right, so getting back to, what is the most appropriate diet for people who have gone through cancer treatment? And here, if you're not familiar with this picture, this is the healthy plate. I guess that's from our newly revised Canada's food guide. And obviously, it's saying eat a variety of healthy foods. Half your plate should be vegetables and fruit. You want to choose whole grains. Make sure that you're getting good protein. Drink water instead of sugary drinks. So my question really, to people is this plate, is this appropriate for everyone, especially if they've gone through cancer? And I think we have to remember that the foods on this plate may not be appropriate for all of our cancer patients. So again, if I have a patient who has gone through pelvic radiation and they're struggling with a lot of diarrhea, choosing whole grain foods may not be the best diet for them, okay? The other question I often ask is, if I have someone who has high blood sugars, should they be eating this type of a plate? This type of a plate may not be appropriate for someone who's managing their blood sugars. So I think keep in mind that for different people, healthy eating may look different and their plate may look different. So we have to keep that in mind. This Canada's Food Guide is based on people being healthy and not going through cancer treatment and having good health and not having diabetes. And when you think about, what the general health of our population, this plate probably isn't appropriate for everyone. So that's something to keep in mind. We think of, a third of our population in Canada has diabetes or pre-diabetes. So maybe this is too much carbohydrate for someone like that. Or like I said, someone who's had pelvic radiation, they may not be able to eat a lot of the foods in the bottom right-hand corner. So I think it has to be really personalized to what that individual's health looks like and what they've been through, how their digestive tract is functioning, and et cetera. Okay. When we talk about, what are the current recommendations for cancer prevention and survivorship, sorry, got another overhead announcement here. Just wait till she's done. Yeah, so I think these are very common recommendations that are often referenced. These come up from the American Institute of Cancer Research, which is a large cancer charity in the States that funds a lot of diet and cancer research. So, I think what their recommendations are is, be at a healthy weight, stay physically active, eat a diet rich in whole grains, vegetables, fruits, and beans, again, which may not be appropriate for everyone. Limit consumption of fast foods and other processed foods. Limit consumption of red and processed meat, and I know that's pretty controversial too. Limit consumption of sugar-sweetened drinks. Limit alcohol consumption. Do not use supplements for cancer prevention. Again, there's just not good evidence to support that. Saying for women who have children, or babies, they should try to breastfeed because that also imparts some immunity benefits to the baby. And then number 10, as you can see, is, after a cancer diagnosis, they're basically saying, follow recommendations 1 till 9. So again, we don't really have a lot of good evidence on what cancer survivors should be eating and what's going to actually reduce their risk of recurrence. I think the other thing, when you look at all of these recommendations, and I know agencies like the American Institute of Cancer Research, they often tout that 30 to 35% of cancers can be prevented by eating this way. At the end of the day, a lot of the research that went into coming up with these guidelines is based on observational studies. So again, we can't really say with certainty that eating this way is going to prevent cancer. And that's unfortunately the reality, is that the quality of evidence to support this isn't as high as it should be. And that's what I always sort of tell people, is that it may not be about, whether you eat one thing or the other thing. We have to start looking at the entire diet and what people are doing with what they eat. So again, a lot of this evidence is not really solid. I'm not saying people shouldn't follow it, but in a way, it's like building a house on a foundation of sand. We need to do better research, is what I'm really saying here.
And Angela, would that include the recommendations about limiting sugar? Because there are a couple questions that we've had here, and I guess you'll probably talk a bit more about this during your presentation, about sugar feeding cancer cells, and also is the keto diet a healthy option for cancer patients? So I did want to mention those now, but I'm sure you'll probably talk a little bit more about that as we go on.
Yeah, those are great questions. We get those questions a lot as dietitians here at Cancer Care. I will touch on that further down because I do want to talk about the role of insulin in terms of its link to cancer. So I'll definitely come back to that for sure.
Okay, great.
Yeah, so I think, at the end of the day, and this is again the same organization that came out with those 10 recommendations, basically saying the available evidence on the effect of diet, nutrition, and physical activity on the risk of all-cause mortality in cancer survivors is limited, and the amount and quality of research in this area is insufficient to make firm conclusions. So again, for us to say that, if you follow those 10 recommendations, you're going to greatly reduce your chance of cancer coming back, we can't say that with really any degree of certainty, unfortunately. And again, I think the whole area of diet and cancer I do think that's going to be the next frontier in cancer research, and it's something that we need to be investigating and studying better than we've done in the past. But having said that, there have been a couple of good studies that have been done looking at diet and cancer recurrence, in particular in relation to breast cancer. So I do want to just talk about some of the evidence that's out there. So back in 2006, 2007, there were actually two large, what we call randomized control trials that were conducted in women who had had early stage breast cancer. And they were trying to figure out, can we reduce recurrence in women with early stage breast cancer? So they looked at there were two trials that got published. One was called the WINS trial. And the WINS trial actually wanted to investigate whether a low-fat diet would be protective against breast cancer coming back. So in this study, it was almost 2,500 women that were enrolled in this study, again, who had early stage postmenopausal breast cancer. So again, keep in mind that postmenopausal breast cancer is the more prevalent type of breast cancer. And they followed these women for 5 years. So basically they had two groups. The women were either randomized into sort of a normal or regular diet group, or they were randomized to be part of the low-fat diet group. And I think in this case, the low-fat diet was less than 20% of calories coming from fat. The other study that was conducted around the same time was called the WELL trial. And in this trial, they wanted to investigate whether having women eat a high fiber, high fruit and vegetable type of diet would be protective in terms of cancer recurrence. So in this trial, they had over 3,000 women. In this case, they had either early stage pre or postmenopausal breast cancer, and they followed these women for 6 years out. And what they found, kind of to everyone's surprise, was that both of these were null studies, meaning that they saw no difference in survival. So they found that in the WINS study, the low-fat diet wasn't protective, that those women were just as likely to have their cancer come back. And even in the WELL trial, the women eating sort of this higher fiber, more fruit and vegetable intake diet, also it didn't protect them against their chances of having their cancer return. There was a small set of women in the WINS trial that did have less cancer recurrence, and it tended to happen in the women that lost weight. Okay, so that was really the only small little nested control out of that study that showed that the women that experienced weight loss seemed to be less likely to have their cancer return. Okay. Interesting, they took a small sample from the WELL trial. So they looked at about 2,400 out of the 3,000 women from the WELL trial. And these are women that had no previous history of diabetes, and they looked at how long they were fasting overnight. So, and this was kind of an interesting discovery that they found, is that when they looked at sort of their overnight fasting duration, they saw that on average, these women had an overnight fast of about 12 and a half hours. So when they split them into two groups, and they said, well, let's look at the women who fasted for under 13 hours and the women who fasted for more than 13 hours, what they found was that the women who had a shorter overnight fasting period, so in this case, under 13 hours, they were more likely to have their cancer come back. Okay, they didn't see that having that shorter, I think I might have a mistake here. The shorter nightly fasting was not associated with significant increased survival. So I think that should say longer nightly fasting. I'm sorry, I think I made an error here. But anyway, what they found was that the women who fasted for a longer period overnight were less likely to have their cancer come back. But at the end of the day, when they looked at overall survival, how long these women survived, it didn't seem to make a significant difference. So again,
Okay.
so there was a delay in their cancer coming back, didn't affect survival, but the women who had the shorter overnight fast were more likely to have their cancer come back sooner, if that makes sense.
Yeah.
So again,
Angela,
observational study, but shows that what's going on here is there, when people eat, is that possibly having a role here?
and there's a lot, of course, in on the internet nowadays about intermittent fasting. And we do have a question from one of our viewers about can it help reduce chemo or post chemo side effects?
Right.
And I'm sure there's a lot of people curious about whether this not eating like overnight, is that considered an intermittent fast? I mean, would that be considered an intermittent fasting if you fast for 13 hours overnight?
Yeah. Well, I think sometimes we call it intermittent fasting. Sometimes it's called time restricted eating, where you're just eating within a certain window of time during the 24-hour period. I think, there's been a lot of studies, there's a lot of interest in fasting right now and whether there are benefits to fasting. So there's different regimens that are being studied, overnight fasting versus fasting 1 day a week, or maybe fasting 48 hours a couple times a month. I think at the end of the day, we haven't really figured out if, there's a lot of people that speculate that fasting is beneficial, can have a therapeutic benefit, but we haven't figured out what the most appropriate dosing is. Okay, so we don't really know, but it's an area where there's a lot of interest. I think getting back to the question about chemotherapy toxicity, again, I think that's a very much an evolving area of research. I don't think we have a lot of really good data on that yet. I think in most studies, we've definitely found that fasting and calorie restriction extends survival in mice with cancer. So whether it does it in humans, we have to figure that out. I think some of the protocols that they're looking at is they are looking at having people fast for 48 hours around the time that they get chemotherapy. And I think the premise behind it is that when healthy cells are put into a fasted state, they stop dividing. So when you think of, which are the healthy cells that get damaged by chemotherapy, it's the rapidly dividing cells. So if you can put the rapidly dividing healthy cells in a fasted state, it may actually protect them from the toxicity of chemotherapy. Cancer cells don't have that luxury. They have this drive to want to continue to divide and grow. So they don't respond to fasting the same way that healthy cells do. So again, I think there's anecdotal evidence that fasting can help reduce treatment side effects due to things like chemotherapy, but I don't think there's enough evidence there at this point that we're recommending it or prescribing fasting. I've had some patients do fasting with treatment, and they actually tolerated treatment quite well. Again, that's anecdotal, but I think that's an area where there's definitely interest. I think, the one thing that we get concerned about is that if people are going to fast, every couple of weeks, depending on how often they get their chemotherapy, our concern would be we wouldn't want them losing a lot of weight because of that. So again, it really depends if, can you make up for those 2 days of not eating, right? Mm-hmm. So again, I think it's a very interesting area to look at and study, but I think we don't have all the answers at this point. So I'm not telling everyone they should go out and fast for 48 hours when they get their chemotherapy, but there may be benefits, Fasting is the problem is today's day and age, none of us fast really because we're always eating, right? And there may be metabolic consequences to that. So I think fasting and like we're going to talk about sugar and low carbohydrate diets, I think there's a lot of interest in those areas and they are starting to be studied. We just don't have all the answers yet. Okay, but I think that's a great question though.
Yeah, we're going to skip our second poll just because we do have a few questions that are in line here for you, Angela, and I know you've got some more slides on sugar and insulin to get to, so just move ahead.
I should keep going?
Sure.
Okay. Mm-hmm. Yeah, so I think, again, when I think of, the audience that I'm speaking to today, women with breast and gynecological cancers, again, I think there's a lot of evidence showing that weight gain and even diabetes are associated with higher risk of women's cancers. And we also know that obesity and diabetes are linked to worse outcomes in these types of cancers. So I think, there is something going on there, especially in these women's cancers. Like, what is the link here between diabetes and obesity and in these types of cancers? When we look at, obesity and cancer risk overall, there's 13 cancers that are linked to obesity, and you can see I've circled breast and, uterine or endometrial cancer and ovarian cancer. We know that these cancers specifically are linked to obesity, and they're also linked to diabetes. Many of these cancers, we see a higher risk with diabetes as well. So I think when you think about, well, what's a common feature between obesity, diabetes, and cancer, I think insulin may be one of the things that is high levels of insulin are common in all of those three disease states, especially when we're talking about women's cancers. So again, I think there's a lot of researchers that are starting to look at the role of insulin as a potent growth factor for cancers. And we know that what and when we eat can have a huge impact on the body's insulin levels, right? So when you think of diabetes, and I'm specifically talking about type 2 diabetes here, it's a disease of too much insulin, or that's how it starts out, right? People think diabetes is just about high blood sugars, but it's really a disease of high insulin. So when we think about, insulin, so again, just for those of you that aren't familiar with insulin, insulin's a hormone that's secreted by our pancreas in response to nutrient intake, right? So we know that when we eat carbohydrate foods in particular, the body will put out more insulin. So our blood levels of insulin are going to rise in response to carbohydrate intake. So that includes sugar and starches. Blood insulin levels also go up slightly with protein intake. Again, the mechanism is a little bit different, but we know that protein, and especially some, the dairy foods can increase insulin, not nearly to the same degree as carbohydrates, however. And then we can see that fats, when we eat fat, like pure fat, it has very little effect on the body's production of insulin. Okay, so again, so there's two ways that you can really lower insulin in the body. Number one is eat less carbohydrate. And the second thing is fast, is don't eat, right? Our insulin levels go up when we eat. If we go through a period of fasting or time-restricted eating, insulin levels are going to drop during that time, okay? So I think, again, insulin plays a lot of different roles in the body. One of the things it does is it helps the cells take up sugar from the blood. So insulin is an important metabolic hormone that it helps to get sugar from the bloodstream into the cells. But the other thing that insulin does as well is it promotes fat storage. So if insulin levels are high, it's going to be very hard for an individual to lose body fat. Okay, and that's why fasting can be so effective for weight loss and fat loss, is because it's almost impossible to lose body fat when you have high levels of insulin around, because insulin actually blocks fat breakdown. Sorry, there's just another overhead announcement in my office here. I'll just give it a few seconds. So my apologies, this is kind of a busy slide here, but there's been a lot of talk about metabolic health and metabolic syndrome. And when we talk about metabolic syndrome, it really can be, a syndrome is something that occurs due to a common cause. And we know that in metabolic syndrome, it involves the disruption of the body's response to insulin. So often our metabolic health gets worse when there's high levels of insulin around and we develop insulin resistance. So how do we tell if someone has metabolic syndrome? Well, we look at those 5 things in the yellow circles there. So when people start to develop high blood pressure, high triglycerides, which are a type of fat in the blood, high blood sugar, central obesity, meaning that most of the That's when people have like a large waist circumference and they carry most of their fat in the central area. And low HDL cholesterol. These are some of the markers of what we call metabolic syndrome. So often if people have 3 out of those 5 indicators there in yellow, we would consider them to be, have metabolic syndrome. Interestingly, they did a study in the US a couple of years back where I think they looked at about 8,000 or 9,000 Americans, and these were people who were taking no medications. And they just, looked at those 5 parameters. And what they found was that only 12% of all the individuals they studied, so again, this is like 8,000 people, only 12% were normal when they looked at those 5 yellow indicators. Okay, so basically they said 88% of all these Americans that they looked at had at least one of those derangements in the yellow. So poor metabolic health is very, very common. And again, a lot of this is being driven by high levels of insulin. So when these problems start to develop and they're around long term, it can lead to those associated disease states, which are listed in the light blue. And you'll see cancer is one of them. That may not be all cancers, but for many cancers, it may actually be linked to metabolic syndrome and high levels of circulating insulin. Like non-alcoholic fatty liver is another example, type 2 diabetes. PCOS is polycystic ovarian syndrome. So again, having cysts on the ovaries. Heart disease, stroke, neurological disorders would be things like Alzheimer's and dementia. So we know that a lot of these disease states are, probably very highly linked to this metabolic syndrome. So again, and we actually figure that high levels of insulin is what's driving this syndrome. And we see that, interestingly enough, they've done some studies in New York, they're doing some research looking at women who develop breast cancer who aren't overweight. So they're looking at women who have normal BMIs, normal body weight. And when they actually assess their metabolic health, they find that they have all these parameters. They have high insulin levels, they have high inflammation, their HDL cholesterol is very low. So even though these women aren't overweight, these are common features that they're seeing in these women who are developing breast cancer. So again, it may not necessarily be so much about someone's weight. It may be more about whether they have metabolic related obesity. And again, we see that with fat being deposited in the organs, in the muscle. Those are the people that seem to be at higher risk of getting many of these cancers. So my question is, should our guidelines, instead of being those 10 that are there, should our guidelines actually be telling people follow an insulin lowering lifestyle? So again, be at a healthy weight, be physically active, because the more muscle you have, the more carbohydrate your body can process healthfully. Should we be telling people to lower their carbohydrate and eat a higher fat diet? So again, what's a ketogenic diet? It's a version of a low carbohydrate diet, right? Managing stress, like that's really important. Keeping cortisol levels low, that helps to lower insulin. Making sure that people are getting adequate sleep. So all of these things are important in terms of lowering insulin. And again, insulin is a very potent growth factor in the body. So and again, this is what we're finding with a lot of cancers. And again, I'll use breast cancer as an example. What they're finding in breast cancer cells is a lot of those breast cancer cells have more insulin receptors on them. So again, it's showing that breast cancer cells are often much more responsive to insulin. So if there's lots of insulin around, that may be potentially driving their growth. Okay, and we know that endometrial cancer is another example where high levels of insulin seem to be linked to those endometrial cancer as well. Okay. So my recommendation to all my patients, you should limit your sugar intake. You should eat less carbohydrate, because I think, again, at the end of the day, our body has no essential need for sugar and carbohydrate. And yet that's what a lot of people eat. So again, if you think about how does what I eat influence my insulin levels, well, sugars and carbohydrates are going to be the things that drive up insulin in the body, which again is linked to cancer growth for many cancers. So I think in terms of, ketogenic diets, again, I think we don't really know for sure. I think they're being studied in cancer. And I know that there are studies that are looking at ketogenic diets in women with breast cancer who are going through treatment. There's studies that are looking at, ketogenic diets in endometrial and ovarian cancer. So those studies are being conducted. We just don't have the results of them yet. I think, unfortunately, the pandemic slowed the recruitment in some of those studies. So I can't really say when those results are going to come out. But I think there's more and more evidence accumulating that maybe a low carbohydrate diet should be the default diet for many cancers. Again, we need more robust evidence at this point. So again, I'm not telling my patients that they should, implement a ketogenic diet. I do have patients that follow the ketogenic diet, and I think if you're going to do it, you should do it, with the advice of a skilled dietitian who's familiar with these diets. But again, I think there's interest looking at them. The verdict is still out, but I think we're heading in that direction.
Angela, there's a couple of related questions, and then there's still a few other questions I'd like to get to, but these relating to keto and insulin. One was a comment from someone that they had lost weight on a healthy keto diet, 30 pounds at one time, but then after diagnosis, they put weight back on, and they said that now they're having time losing the weight on the same keto diet. I guess they're also taking some other medications that I can't pronounce, so I won't even try.
Yeah.
But is that common for people to experience weight loss, maybe at once with this, but then not always consistently?
Yeah, I think it's not uncommon for people to hit plateaus. I think sometimes if you're already following a low carbohydrate diet, maybe you want to combine that with some time restricted eating if that's appropriate. So I think there's ways you can rejig it a bit. For some people following ketogenic diets, they may not be getting into ketosis, into that real good fat burning mode. So if you're not checking for that, you don't really know. Sometimes just eating too much protein can hinder your progress too. So again, I think if you're doing that, following that kind of a diet and you're not having progress, it might be worth speaking with a dietitian, have someone review what you're doing. Maybe you can make some tweaks along the way.
Yeah, good idea.
Yeah,
another
I think
question. Oh, sorry, another question, Angela. How come insulin and insulin GF, I believe that says, are not considered in the blood work of breast cancer patients, particularly if they are not obese or diabetic?
Yeah, I think that's a great question. I think we're starting to do more metabolic profiling of tumors, where we test tumor samples for different mutations, for instance. Yeah, I think at this point, even looking at, insulin receptors or insulin growth factor receptors, really that's only being done in clinical trials at this point. But I think that's a great question. I would love to see that in all of our patients. Like if you knew someone's tumor was overexpressing insulin receptors, absolutely you'd want to put them on a low carbohydrate diet, right? But yeah, I think we're not there yet, right? There's all sorts of issues why we don't, there's a lot of tumor testing that we'd probably like to see done in clinical practice, and we're just not there yet.
Yeah.
But that's a great question, though. Maybe in the future we will have that.
What about the role of stress and inflammation and hormonal changes? Is that all related to what you're discussing here, Angela?
Well, I think stress can definitely, affect things too. Like I said, when you think of cortisol, which is our common stress hormone. So when we're stressed, our body's cortisol production goes up, and that can cause blood sugars to elevate, which in turn can cause more insulin secretion from the pancreas. So there probably is, to say it's just about insulin is probably oversimplifying it. There's probably other factors. But I will say, in diabetes, they've done some very interesting research looking at ketogenic diets. And when they put people with diabetes on ketogenic diets, they see that the markers of inflammation improve. They see that insulin levels go down. They see that people lose weight. Liver fat starts to go away, like, blood pressure goes down. All of those markers of metabolic syndrome improve on a ketogenic diet. And we've seen that in studies looking at diabetes. And I always tell the physicians, we don't have one drug that does all of that, So I think there is something there with ketogenic diets that, again, can have a very dramatic effect on metabolic health. And that's why we should be curious about them, and that's why we should be studying them. The problem is that diet-related studies just don't get conducted as quickly as drug studies do because the financial incentive isn't there. So, that's part of the reason is that it's hard for these researchers to find sustained funding for diet-related studies, which is really sad, but that's the reality that we live in right now.
Can we ask you a few more questions, Angela, or do you have some other
sure.
slides you want to get to? Okay, somebody asked about recommendations for a person who's HER2 negative, unable to take hormone therapy to assist with recurrence and prevention. Are there any sort of food suggestions for somebody that has that type of breast cancer?
Yeah. Again, I think it's so hard to know, right? I think the way I look at it is, at the end of the day, cancer is a disease of growth, and we want to set up an environment where these cancer cells can't thrive in, right? So if there are a lot of growth factors like insulin around, if there's lots of glucose in the blood around for these cells to take up, I would say, I think from a physiological point of view, the best way to look at that is low carbohydrate diet. Is lower your carbs, increase your fat. I can't say for sure whether that's going to help someone with a HER2 negative breast cancer, but I think telling people just follow Canada's food guide or eat a plant-based diet, we don't have good evidence to support that. We don't even have a mechanism that supports that. So, I think like I said, lowering growth factors like insulin in the body may actually be the best advice we can give people. I mean, I hate to say it, and I'm not saying people should go out there and stress if they have a piece of cake on their birthday. Like, having a little bit of sugar isn't going to send your cancer growth out of control. But again, I think in generally speaking, and that's why I think if people have extra weight to spare, they should look at some weight loss. Because again, in order to lose weight, you drive down growth factors, right? If you're already really slim and you can't afford to lose any weight, that's probably not the best option for you, right? Mm-hmm. But I think, like I said, most people have high levels of insulin. You and I might have high levels of insulin in our body, Kathleen, and we don't know.
Sure, I do, actually.
Yeah. And the problem is it doesn't get measured, right? Mm-hmm. I think, blood sugars don't correlate to cancer risk, but high insulin levels do. Mm-hmm. And it's too bad that insulin isn't something that we check more often. And even fasting insulin isn't useful. We have to look at how the body puts out insulin in response to sugar intake. And we don't know that with most of the lab tests that we do.
Angela, also another question about are there certain foods that are ideal or foods to avoid if your cancer is estrogen and progesterone positive?
Yeah, again, I don't know if we have really good evidence. I know, in the past, we've always been worried about soy intake and, are the phytoestrogens in soy foods, do they drive estrogen responsive tumors? I think, again, the evidence hasn't been good there. We do tell people that, hey, you can have a bit of soy in your diet, soy foods anyway. I think for me, I tell people that, hormone levels aren't necessarily influenced specifically by the types of foods we eat. It probably is influenced more by our metabolic state that we're in. So again, if someone's in a hyperinsulinemic state, that might actually be driving it. I think obviously, again, the thought that if you have more body fat, that might influence estrogen levels in the body too, right? That might drive inflammation. So I think trying to reduce body fat is probably important.
Okay, we're out of time, but I do want to see if we can just quickly answer 3 more questions. One was about after antibiotic use, can you improve the microbiome better, like by eating certain foods or increasing your fiber in your diet or other foods? Is there any recommendations following antibiotics?
Yeah, I think you want to sort of gradually get back, more plant foods into your diet. I mean, the type of microbiomes that we have or microbes we have in our digestive system is very much influenced by what we eat. So I think, the more diversity you want in your microbiome, that can be improved by having more variety in your diet, by, having vegetables and fruits and things like that in your diet. So again, we know that what we eat and the variety that we eat can influence those gut microbiomes, that gut microbiome. But that's very individual from person to person too.
Right.
I think, studying the microbiome, again, it's still an emerging area of research right now. We don't have the answer. I think some people are looking at the microbiome and its relation to immunotherapy, but again, that's very early evidence that's coming out on that. So it's, I think, again, as you're recovering from long-term antibiotic use, you want to sort of get more variety back into your diet, get more plant foods in there. And again, but it's very individual too.
Okay. And how about somebody asked about their appetite being up and down? Are there any suggestions to improve appetite?
If appetite is low?
Well, I guess, yeah, I guess that would be the concern.
Yeah, well, I think at the end of the day, we don't have a lot of good, we definitely don't have a lot of good medications that we can give for appetite stimulation. I always tell people sometimes it's just eating by the clock. You just have to find ways to eat, so that you don't feel worse after you eat. But I think it's really important too that if you can only eat a certain amount, that you get in the most nutritious food. You make every bite count, right? So don't fill up on Pop-Tarts and just crackers. You will get your protein in, get some healthy fats in, try to eat some vegetables if you can. Maybe you take a multivitamin if your diet is really limited. But yeah, poor appetite's a tough one. I think I always tell people, make sure that there's not some symptoms there that are causing your poor appetite. So if you're having a lot of nausea or if you're having pain and those things are causing your appetite to be reduced, we can address nausea, we can address pain. We have good strategies to control those types of side effects. Sometimes poor appetite goes hand in hand with cancer. And we see that in people who, especially if they have advanced cancer, is that the cancer cells are secreting hormones and substances in the body, which can really reduce the desire to eat too. So sometimes it's just a direct link to the cancer and we can't really do much about it. But if you have side effects that can be modified or managed that are interfering with your appetite, it's really important that you aggressively manage those side effects.
Good to know. Last question, somebody asked if you or Cancer Care is participating in any studies about diet and breast cancer.
Not that I know of.
No.
Again, unfortunately in my practice, I'm not really involved with a lot of research. With our staffing, we kind of do more direct patient care. Like I said, I think there are some very interesting studies looking at diet and breast cancer. I'm not sure if there's anything done here, not that I'm aware of.
Okay.
Like I said, I know Ohio State's doing some interesting research in breast cancer and keto. In New York, they're doing some really interesting research there too. I wouldn't say diet and cancer research is a huge priority here right now, unfortunately. But that's the truth.
Yeah, I know you do have a slide, Angela, about the resources that are available through Cancer Care that you want to share.
Yeah, I'll just quickly share this. So again, we do have, here at Cancer Care, we have 3 dietitians. We're not all full-time, so it's equivalent to having 2.5 full-time dietitians. So there's Robin, Ranu, and myself. Robin goes to the St. Boniface unit 2 days a week. She's also at the Victoria General 1 day a week and comes here to the HSC location twice a month. Ranu and I work primarily here at the McCharles site, which is the HSC site. And then we also have Beth. She's a full-time dietitian. She works over at the Breast Health Center. So she tends to just follow women with breast cancer. So she's a resource that's available. I think for referrals, we will accept referrals from any member of the healthcare team. We also take self-referrals. So if there's any women out there who want to get hooked up with a dietitian, you don't have to get a referral from your healthcare team. You can just contact us directly. So if you do want to meet with someone, you can call the number there, the 787-2109, or the toll-free number. I guess you can't really drop by nutrition services right now because of COVID, but like I said, we're just a phone call away. And if you want to just have a phone call with a dietitian, or if you have questions, or if you want to do a more thorough assessment, our services are here. We try to keep the wait times pretty short as much as possible. Most of our visits right now we are doing over the phone. I mean, I will do a Zoom call with people if that's their preference. Unfortunately, we're not sort of bringing people in for in-person visits right now. We will see patients if they happen to be coming into the clinic to see the doctor. If they're up on the treatment floor, we are going to see patients there. But like I said, we're trying to limit the traffic through here right now because of COVID, unfortunately. But anyway, we are available by phone and email, and you can just give the secretary a call and set something up if you're interested.
Thank you so much, Angela. You're always so interesting to listen to and generates lots of questions, and it's fascinating, the link between diet and our health, and the research, the lack of research too, that's not going on, that we wish would go on to find out more about this. But we really appreciate you joining us